Good morning, and welcome to Medicine Grand Rounds. It's great to see a bunch of you here already. There are people coming in the door. It's a good day when we run out of donuts. Today, it's really my pleasure to introduce Adnan Said, who's presenting Grand Rounds today. Dr. Said is a graduate with an MBBS from the Aga Khan University Medical College in Karachi. He then was recruited to our residency, where he distinguished himself and went on to fellowship and also took an MS in population health here at the University of Wisconsin. He then joined the faculty in the Division of Gastroenterology and Hepatology as an assistant professor, and currently is associate professor, program director for Transplant Hepatology Fellowship, and the medical director of the VA Liver Transplant Program and chief of the VA GI and Hepatology programs. He's published broadly. I count 59 publications in peer-reviewed journals, all focusing in GI and hepatology, and he's authored 12 book chapters. He's receiving current grant support from the VA, the NIH, ICTR, and industry, and he's previously been supported by the American Gastroenterological Association. He's an active and avid educator at all levels, including classroom, clinical, residency, fellowship, CME, and he's been a mentor to fellows and faculty alike, and even is a mentor for one PhD candidate currently. He's been invited to give research presentations both nationally and internationally. He's a good citizen at all levels. He's a member of the Department of Medicine Research Committee and participates in the Department of Medicine Post-Promotion Review Committee. He's a member of the UW IRB and serves on 3 editorial boards and is associate editor of Clinical Liver Disease. He also serves on the American Association for the Study of Liver Disease Practice Guidelines Committee. Along the way, he's received a number of honors, too many to mention, but among them, the American Gastroenterological Association Research Scholar Award, Best Poster Award from the Department of Medicine Research Day. He's listed in Best Doctors in America, and most impressive, 3 times he's been named Educator of the Year by the GI division. So consistent with a theme, we have world experts here, and we're so fortunate to have them provide grand rounds in addition to the visiting professors that we have throughout the year. Today, I'm really privileged to introduce Dr. Said as he presents grand rounds entitled From Obesity to Opioids, Liver Transplantation Trends in the United States. Please join me in welcoming Dr. Said. Thank you very much.
Thanks very much, Rick, for that extremely kind introduction. Welcome, everyone. Here is the title of my talk. I have no financial disclosures. And here are the objectives. We will examine shifting trends in liver transplantation in the United States. Next, I'll go on to review the impact of an important epidemic, the obesity epidemic, with in particular context to non-alcoholic fatty liver disease and how it refers to liver transplant in particular. And then finally finish by discussing the impact of the opioid epidemic as it pertains to transplant donation. So let me give you a little bit of history about liver transplantation. In what we call the Premal Era, prior to 2002, there were a lot of inequities in organ allocation and transplant. The way that transplant was triaged was according to a scoring system that did not discriminate well between differing risk of mortality. And so waiting time on the list became as important, if not more important, than the degree of illness. And so there was a lot of inequity. The Institute of Medicine at that time published a report highlighting the critical need for allocation according to degree of illness. And the transplant community got together and did an excellent job of coming up with a system that now we use for transplant allocation, and that's the MEL score, stands for Model for End-Stage Liver Disease. It is used to place patients on the liver transplanting waiting list, and it relates to pre-transplant risk of mortality very well. You all know it. And if you don't, it includes creatinine, bilirubin, INR, sodium in a weighted formula. And it has been in place since February of 2002. So I'll show you a few trends about liver transplant in general, and then we'll talk about this specific disease that I mentioned. So what happened after MELT was implemented in early 2002? Well, it did what it was supposed to. Waiting list mortality fell. We did more transplants. These are the number of transplants per year, which is great. Then around 2008, we reached a peak, and things stagnated. It wasn't that there weren't patients on the waiting list who really needed livers or people were not dying of liver disease, but we reached a peak in the number of transplants and donors at that time. And that has continued up until maybe the last 3 years, 3 to 4 years. There has been a small surge in the number of transplants in the United States, all kinds of transplants, and this were multiple factors, some of which I will allude to later. What else has happened since the MELT score? Mortality on the wait list has decreased. This is excellent. But you also have to look at this metric. These are patients who are placed on transplant waiting lists and then removed by their centers because they were too sick to transplant. And that has tripled in the same time. So if you combine these two, since this is de facto mortality, we're about the same place as we were in 2002. So although the number of transplants have gone up, the liver transplant list continues to grow, the need for transplant continues, and there is still a gap between the number of transplants and the number of patients who need a liver transplant. So what are the recent trends? Well, if anybody has worked on the wards or in liver transplant, they know that hepatitis C has been king so far. Since the 90s up till now, Hep C has dominated the liver transplant waiting list, accounting for 70% of all transplants as an underlying diagnosis. But is that going to remain the same? And it is not. There have already been changes. On the left are number of new registrations, patients placed on the transplant waiting list, and these are actual transplants. Here's hepatitis C. It was slowly decreasing, but in the last 2-3 years, it has continued a steep decline. Non-alcoholic fatty liver disease has kept increasing gradually for both registrations and transplants, and alcohol remains stable, but over the last 2-3 years, it has gone up. And then there's this. That is hepatocellular carcinoma. Liver cancer is now the number one reason for listing and transplanting patients in the United States. So what causes this liver cancer? The biggest burden is still hepatitis C, but the new cases, the incidence has plateaued and is coming down actually. And non-alcoholic fatty liver disease related liver cancer is increasing over 10% every year. This is foie gras. It's goose liver, it's delicious. But I do not recommend it. If anybody of you know how foie gras is made, it's fairly inhuman. It's duck and geese that are gavaged. This funnel is shoved down their throat, and they are gavaged with food, corn mush, usually daily, until the livers get swollen and fatty, and then they are served to us. Non-alcoholic fatty liver disease is human foie gras, but nobody's gavaging us but ourselves. I used to show this slide to the medical students when I talked about hepatitis C, and these are celebrities that are living with, have been treated for, or in the case of Mr. Evil Knievel, have received a transplant for hepatitis C. Unfortunately, he passed away. The rest are still around. But when you talk about non-alcoholic fatty liver disease, I get jealous because no celebrity has come out announcing their NAFLD. But I scoured the internet, and I did find one. Poor George Michael passed away, I think, last year. And although he did not announce fatty liver disease, the coroner diagnosed him with heart failure and fatty liver disease. Whether it's non-alcohol, we don't know, but that's the coroner's report. So we will claim that. So what about at a population level? I showed you transplant level data so far. For NAFLD-related liver cancer, it's even more dire. As you know, NAFLD is a hepatic manifestation of the metabolic syndrome. It's intimately linked to obesity and diabetes, hypertension, hyperlipidemia. And although for an individual patient, the lifetime risk of liver cancer is low, the sheer burden of non-alcoholic fatty liver disease makes it so that the majority of the liver cancers out there in the community that we are seeing and will continue to see, over a third, will be from non-alcoholic fatty liver disease. And it's no surprise that non-alcoholic fatty liver disease, or NAFLD, is increasing. It is closely linked to the obesity epidemic. Here in the US, dark red and purple is bad. These indicate state prevalences of obesity. You all are intimately familiar with this. There is no state with less than 20% obesity. We're at over 30% obesity right here, and it continues to rise. This is from 1990 to 2015 in Louisiana. And in this study that was done a while ago, it's an elegant cohort study of 900,000 US individuals. It has been shown that many cancers go up with obesity. Breast cancer, prostate cancer, kidney cancer. But the highest relative risk in this study back there in 2003 was reported with liver cancer, a relative risk of over 4.5. This is a correlation we see worldwide. This is prevalence of obesity here on the x-axis in the population, and this is liver cancer mortality. In the US, it goes up with the obesity fairly well, same in Turkey. There are other countries where the liver cancer mortality is very high due to viral hepatitis, and there the trend does not follow. And childhood obesity takes place early. It takes place before kindergarten. This is a study of US school children, males and females, looking at prevalence of obesity by age group. This is an age group from 2 to 5 years. Prevalence of obesity is under 9%. Not great, but not super high. Same cohort, 6 to 11 years later, obesity is 17.5%. And the Danes follow everybody. They do great population studies, and they have shown that what happens in childhood tends to follow you through life. So these are children who had BMI reported, over 280,000 children in Denmark, and they had follow-up for over 60 years looking back, and they looked at liver cancer. It was found in both boys and girls, more commonly in boys, and it correlated well with BMI in childhood between the ages of 7 and 13. So if a 13-year-old boy weighs 43 kilograms, a boy of similar height weighing just 6 kilograms more had a 30% increased risk of liver cancer 60 years later. So what is the spectrum of obesity-related liver disease that we are seeing? At the bottom of the pyramid, the big one is NAFLD, or isolated steatosis, just fat in the liver, no inflammation. But it can lead to, in a smaller proportion of patients, NASH, or non-alcoholic steatohepatitis, where there's inflammation, cell death, and this is the progressive form. This is the form that can lead to fibrosis, can lead to cirrhosis, end-stage liver disease, and the risk of liver cancer. Diabetes carries additive risks. And these are projections between 2015 and 2030 of end-stage complications of NAFLD. So this is decompensated cirrhosis, complications that you see on the wards, ascites, jaundice, variceal hemorrhage. Those are expected to increase by 160%. These are liver-related deaths, same percent, and liver cancer increasing by 137% if nothing changes. What about population data? This is from SEER Medicare in the population, and this is just 1 year follow-up of all patients diagnosed with liver cancer. Really dismal outcomes. For non-alcoholic fatty liver disease, about 60% die within a year of diagnosis. Hep C is a little better, but not by much, maybe 30, 35%. So what are the reasons? If you drill down further, this is data from the VA, which was published a little while ago, between 2005 and 2010. And they compared everyone with a diagnosis of non-alcoholic fatty liver disease-related liver cancer with Hep C-related liver cancer. And one big difference they found was, look at the detection of liver cancer and Hep C. It was found by surveillance, periodic screening in cirrhotics, 87% of the time. Whereas in NAFLD, only 43% were getting surveillance. We do surveillance by periodic imaging, most commonly ultrasounds every 6 months when you have cirrhosis. Now Hep C, this is excellent because Hep C has been a priority for the VA. They have done a great job of screening, detecting, and treating patients. But NAFLD is not so easy. There is no single blood test that will tell you that a patient with diabetes or obesity has NAFLD. Cannot rely on liver enzymes. So what's the consequence? The stage of liver cancer is shifted towards more extensive, larger tumors outside the liver in NAFLD. Early stage cancer, where it's still curable, was found only in 6% of NAFLD and in 16% of Hep C. As a result, curative treatments, which could include liver transplant, resection, ablation, were possible or done in only 11% of NAFLD patients versus 22% of Hep C patients. The other important thing in this slide is, who do we screen for hepatocellular carcinoma? Cirrhosis, right? That's the smallest part of that pyramid, becomes relatively easy, and that's true for Hep C. For NAFLD, that's what we're doing right now. But this study, and some others have shown as well, that a significant proportion of liver cancer in NAFLD occurs in non-cirrhotic patients, or patients that you cannot diagnose as having cirrhosis. So a third in this population. And that's a much bigger pie. And we see this in other studies as well. These are European studies. This is an Italian cohort. This is a UK cohort. Same thing. Surveillance done for Hep C cancer 63% of the time versus 48% for NAFLD cancer. This is in Italy. In the UK, non-cirrhotic liver cancer, 23% in NAFLD. So NAFLD HCC patients are older. They have advanced stages of disease, and they're often found in non-cirrhotic liver. It makes it challenging, as well as the comorbidities that these patients have. So what about this problem of non-cirrhotic liver cancer in NASH? What increases the risk? We know diabetes and obesity add to the risk in a non-cirrhotic patient. Is there any evidence that treating those conditions, reversing them, makes a difference? Nothing prospective, no randomized trials, but there is interesting epidemiologic data I can show you later that suggests that controlling diabetes may reduce the risk. True with metformin, possibly. There's an interesting genetic association of fatty liver disease and liver cancer with this single nucleotide polymorphism, PNPLA3. This was found originally in the Dallas Heart Study, and it correlates with your risk of developing fatty liver disease, cirrhosis from it, and liver cancer, odds ratio of 1.92. This single nucleotide polymorphism has an interesting ethnic association. So it is found in 45% of Hispanics in the U.S., 33% of Caucasians, and 25% of African Americans. And it mirrors fairly closely the risk of developing NAFLD in these populations when they have diabetes. So what about liver transplant? For NAFLD, for HCC and decompensated cirrhosis put together, NAFLD has been the fastest increasing indication for liver transplant and will continue to grow. It's the only one that's growing. There's been a 170% increase over the last decade. And what are the challenges? These patients, as a result of the underlying milieu, metabolic syndrome, have more comorbidities. Obesity, diabetes, history of coronary artery disease, so higher risk of being delisted. Post-transplant, they do use more resources, increased risk of infection, ICU stay, cardiovascular risk. But with careful selection and intensive follow-up, the results are excellent, same as any other liver disease for patient and graft survival. But at this rate, with NAFLD, we would like to help all the patients with transplant, resection, and ablation, but we will not be able to with the burden of liver disease. So what are the strategies where you can slow the growth of NAFLD or give therapies to reduce progression to cirrhosis? Now here I'm going to give credit to one of my mentors, Dr. Pat Remington, in the School of Public Health. He likes to talk about upstream effects. This is an example he used, which I liked. So here's this elite trained team. They are rescuers. They are well trained. They rescue people that are drowning down in the rapids. Every day they do this. They spend a lot of time, they spend a lot of effort, and they do heroic work rescuing many desperate people. And they do it day after day after day. One day they said, let's go up. Where are these people coming from? So they go upstream that river. And here's a group having fun, playing with a dolphin. They're not in trouble now, but occasionally one of them gets pulled under the undercurrent, probably chasing that dolphin. And they found that if I had just planted that sign upstream, strong undertow, be careful, we could have saved a lot of effort downstream. So here's a nice quote from Bishop Desmond Tutu won the Nobel Peace Prize. There comes a point where we need to just stop pulling people out of the river. We need to go upstream and find out why they're falling in. And when you talk about chronic liver disease models, this is what we should look at. What is the upstream problem that leads to the downstream issues of cirrhosis and liver cancer, obesity and NASH? What can we do about it? Reducing sugar, taxing it, school lunches, walkable neighborhoods, many, many things that are being done that are critically important. Having said that about upstream, I will now spend all my time downstream. The human body is like an engine, right? Whatever calories we take in, we burn. If we take in more, we gain weight. Excess calories, particularly sugars, get stored as triglycerides in the adipose tissue and in the liver, where it becomes steatosis. But here's a bear just before hibernation. This is not to show you that we are bears. We are not bears. Bears can gain twice their body weight before hibernation. If you and I did that from eating, we'd all develop diabetes that month. Bears never do. So there was an interesting study where this group of researchers gave these bears insulin, a level of insulin they thought that would be appropriate, and they almost all died from hypoglycemia. So they remain very insulin sensitive despite gaining this weight. How do they do this? There is an interesting mechanism that is still being looked at in their liver. It's like a dimmer switch. There's a protein that turns on and off, and it maintains the bear insulin sensitive even when it gains all this adipose tissue. We cannot turn it on and off, but there is research going on. If you have time, go look at it in this month's Hepatology. So what works for NAFLD in your clinic or NASH in your clinic? Weight loss works. It works better than almost any drug that's out there. How many drugs are approved for NAFLD? 0. So that's not hard. But it's hard to do. Right, here's a randomized controlled trial of weight loss. It's not easy. The control arm was seen by a dietitian every 12 weeks in a liver clinic. That's a control arm. The lifestyle arm was seen every week. So a lot of effort. Food diaries, exercise programs, and when people lost between 7 and 10% of body weight in that year, within 6 months, there was marked improvements in NAFLD histology. So in markers of inflammation, steatosis, ballooning in the liver in a short period of time. Coffee possibly works. There's no randomized trials yet, but there is tons of data. Journals are even dedicating whole issues to it. It is reduced epidemiologically with reduced benefit, with the increased benefit and reduced risk of liver cancer. So enjoy your coffee and mind the donuts. So up here is healthy liver, fatty liver, progressive NASH, and cirrhosis, weight loss, exercise, controlling metabolic syndrome, exceedingly important. What about when you're coming to our clinics here with NASH? What can we offer you in addition to these things which remain the backbone? Well, one class of agents that have been used in diabetes, the so-called PPAR gamma agonists, work for diabetes. They have been tested initially in pilot trials and now in several randomized controlled trials. They redistribute fat from the liver to the adipocytes. They improve insulin sensitivity. They increase levels of this good adipokine called adiponectin and reduce the flux of fatty acids into the liver. This is a meta-analysis of trials that we published from our group showing that they do improve liver histology. So ballooning, steatosis or fat in the liver, inflammation in the liver, all are improved with 48 to 72 weeks of this agent, pioglitazone. Fibrosis does not. It improves insulin resistance, reduces triglycerides, improves liver enzymes. Unfortunately, body weight goes up, which can be a problem for fatty liver disease. So there's some controversy. There are other issues with pioglitazone as well. Some risk of congestive heart failure in a minority of patients and edema. Vitamin E, common antioxidant. It has been tested in a few randomized controlled trials in NASH as well. Inhibits apoptosis and works on inflammation. And the results from our meta-analysis has shown that it does improve ballooning, it does improve fat, steatosis, and inflammation. Does not change fibrosis. There are concerns with long-term use with vitamin E, small effects on all-cause mortality, hemorrhagic stroke, and maybe prostate cancer. So you do have to talk to your patients about it. When would I use it? I would consider pioglitazone in diabetics with NASH, progressive NASH with fibrosis, and vitamin E in non-diabetics after discussing the benefits with them. When you use these agents, you would need to do a biopsy. And none of them reduce fibrosis. What about metformin? Great drug. Pilot trials showed possible benefit, right? And these are NASH trials. No benefit in any of the markers. So metformin is out as a specific treatment for NASH. I wouldn't give up on it, though. There is pretty compelling epidemiologic evidence, with all its biases, that metformin in diabetics with NASH-related cirrhosis may have some benefits in reduced cancer. So these are patients with NASH cirrhosis who were on metformin, continued it, and these are people who started on it and had to discontinue it. And cancer risk and survival is much better in those who continued metformin. And there are plausible mechanisms for the anti-cancer effect of metformin, including on apoptosis, angiogenesis, and protein synthesis. Meta-analyses have shown that these are all epidemiologic studies, and metformin may reduce the risk of liver cancer, or at least is associated with less liver cancer risk in diabetics. 7% reduction with each incremental year in metformin. What about statins? They also have theoretical benefits for cancer, right? No randomized controlled trials showing this. There is a small trial in NASH showing possible benefit of Crestor, but it's a pilot trial. But we and others have looked at statins. This is a nested case control study we did in liver cancer for NASH. looking at many factors. One of the things that came out, and we're presenting this year at the liver meetings, is that statins were protective in HCC NAFLD compared to matched controls with NAFLD. And again, meta-analyses showing that maybe a 50% or 53% reduction in odds of liver cancer on patients on statin. So that's everything that's out there. They're not specific for NAFLD, but you can use them. They do not have FDA's label indications for NASH. But what's coming down the pike, there's a lot of trials out there. There's a lot of research in this area similar to what was happening for Hep C for the last 15 years. These are the number of trials worldwide for NAFLD before 2010, and now there's more than triple. A lot of studies. There are multiple pathways we are learning about where these drugs would work. Some in the intestine, some in the liver. Some work on fat deposition and metabolic stress, some work on oxidative stress and inflammation, and a few on even fibrosis. I'll show you a couple of examples. Or you can go to Amazon.com. This is one of, and remove your fat deposits from the liver for $127. They'll probably sell a lot more than any drug that's going to be approved. So the new kid on the block is obeticholic acid. It's in phase 3 trials. We are participating. If you have any patient who's interested, I would love to see them. This is a lipophilic bile acid. It's a potent activator of the farnesoid nuclear receptor, or FXR, and it's taken orally. What does it do? It reduces bile acid signaling, reduces bile acid synthesis in the liver, improves insulin sensitivity, decreases gluconeogenesis in the liver, and it decreases triglycerides in the liver by decreasing hepatic lipid synthesis and increasing clearance. Here's the Flynn trial, a phase 2 randomized controlled trial with obeticholic acid that was published in The Lancet a couple of years ago, and it showed compelling changes in liver histology. So there were improvements in markers of fat and inflammation in the liver with obeticholic acid compared to placebo. And even more impressively, this is the first agent that showed improvement in fibrosis. So it remains to be tested in the phase 3 trial whether this persists. Liraglutide used diabetes GLP-1 analog. There is a phase 2 study in NASH showing possible benefit, small study of 52 patients, showing that histologic resolution of inflammation occurs in 39% versus 9% in placebo. No change in fibrosis, although worsening was less. Phase 3 trials are awaited. The potentially interesting thing about this agent is that it promotes weight loss and reduces appetite. So that's all about NASH. I will spend the remaining time briefly discussing an important epidemic that is facing the entire country, and that's the opioid epidemic. There are more Americans dying, unfortunately, from an opioid overdose daily than people getting any kind of transplant, all combined. Wisconsin is not immune to this as well. It is the leading cause of injury-related deaths now, higher than falls, higher than motor vehicle accidents. And what is the impact of this in the field of liver transplantation? One of the unintended consequences of this tragedy is increase in donations from drug overdose. So as you see here, these are the number of donors who died of drug overdose from 2003, 2007, 10, and 2014. Darker blue means more donors. And progressively every year we have had more donors throughout the country passing away from drug overdose. So increasing overall up to 7%, bigger problem in our younger population, 11% of all donors are under 40. These patients and their families donate at high rates. In fact, donors that die of drug overdose have the highest rate of organ donation, more so than other causes of death, including gunshots, strokes, cardiovascular disease. I think it gives some of these patients' families some comfort in a horrible situation to know that their loved one could help somebody else, and thus we see high donation rates. Yet despite this, the mean number of organs that we transplant per eligible donor, somebody that is an eligible donor from a drug overdose, is significantly lower from drug overdose as compared to any other cause. Why is that? Part of the apprehension is the risk of transmitting infections from a recent drug user. These donors all get exhaustively tested now. It's mandated. They all get tested for nucleic acid testing for HIV, Hep B, Hep C. And although it is possible, of course, that there could be a window period where a donor who's negative could transmit one of these viruses, that risk is low. You see the risk here is published, 2.7 per 100,000 for HIV and 10 per 100,000 person years for Hep C. So that means at the most 2 to 4 cases of unintentional transmission of any of these agents all put together in now over 30,000 transplants in the US, in some years none. The risk of dying on the wait list for a transplant far exceeds the risk of transmitting any of these diseases. One of the things we are seeing, even though Hep C is going down, in young patients there is a small increase from drug use seen throughout the country, over 200% increase in Wisconsin, lots of the Midwest, Pennsylvania. So when these patients donate and they have Hep C, what do you do? So it has been routine practice for decades that a Hep C positive organ can be transplanted as long as there is no damage to the liver and these get biopsied in a Hep C positive recipient. And the results are excellent. No difference in long-term outcome between such a pair as compared to a Hep C recipient who received a negative donor. So this is routine clinical practice. It's acceptable. But the apprehension, of course, from recent drug users remains. But it's getting better. This is the percent of Hep C positive deceased donor liver transplant recipients who received a Hep C positive donor liver. This is in the interferon era. This was 5%, and it has increased up to slightly over 15% now in the non-interferon era when we can effectively treat Hep C. So there is increased utilization. However, compared to Hep C negative livers, the Hep C positive livers are still discarded 1.7 times more often, or not used or not accepted. The main concern in the past regarding the use of these grafts was that you're going to transmit a virus and you won't be able to treat it after transplant, and that was true. In the era of interferon, response rates were under 30%. After a year, there was a lot of side effects, lots of interactions. Some transplant recipients, like kidney transplant recipients, couldn't even get it because of the risk of rejection with interferon. But that is no longer true. In the era of direct-acting antivirals, interferon is not even recommended for anyone with hepatitis C, and in patients without cirrhosis post-transplant, cure rates are in excess of 90%, in excess of 95% most of the time, with regimens that are exceedingly well tolerated, often include 1 pill a day sometimes, with or without ribavirin, and last 8 to 12 weeks. But where's the data? So Goldberg and colleagues thought about it, and they said, let's do a randomized clinical trial. And they presented it at the last transplant meeting, and it's now in the New England Journal. They took adults who were on the kidney transplant waiting list, who were undergoing dialysis, who did not have conditions that had increased risk of liver disease. These are, remember, CKD patients. And they did a 3-step informed consent process in this trial. They gave Hep C positive kidneys, which can also transmit Hep C, to Hep C negative recipients. They measured the viral load on post-op day 3. They confirmed the virus was present, and then they gave them a direct-acting agent. This pill is taken once a day, elbasovir/grazaprovir, and this therapy was maintained for 12 weeks. There's 4 different regimens you could use. Which one you're using doesn't matter. And what are the results? The Hep C viral load came down sharply, as expected, in all of these 10 recipients, remained negative, and they have been cured of transplant of Hep C over long-term follow-up, and there has been no decline of kidney function. So I would say there's a lot of pros to considering Hep C positive donors that want to donate. It shortens time on the waiting list. It gives a desperate patient, somebody who's sick, access to a life-saving transplant. There's no difference in outcomes when they're transplanted in Hep C positive recipients, a lot of data, and some preliminary studies showing that in Hep C negative recipients. And the outcomes are probably better than some other extended criteria donors that we use, like DCD. We use Hep B core positive grafts. They have to be on entecavir forever as well. So this, to me, is an even better option because there is effective short duration therapy available to eradicate the virus. You have to be careful, not in chronic Hep C donors, that you don't take somebody with fibrosis, but they all get biopsies. Resistance to antivirals does not exist with the polymerase inhibitor, especially in acute infections. The main issue is coverage and cost. Are you going to get insurance coverage or whatever coverage you have for these patients to cover it? The other risk is while they have Hep C, because they will all get Hep C if you transplant a donor, they can transmit Hep C to contacts, sexual contacts, or if they're sharing needles, and so they have to be told about precautions for that while they have Hep C. Every such transplant should receive early preemptive therapy with antivirals, which are easily available now. However, until this is shown to be clearly efficacious, centers performing this transplant should have a rigorous consent process, institutional review, vetted for safety and adequacy. We have to tell patients there is no guarantee that you will have coverage for antivirals until we do. So I will conclude now, and we talked about the large gap between the number of liver waitlisted candidates and transplant recipients that still persists. The good news, there is decline in Hep C decompensated cirrhosis, and liver cancer from this is peaked as well and will come down. This will unfortunately be offset by increasing NAFLD cirrhosis and NAFLD liver cancer. These require a lot of resource utilization. There is going to be more HCC morbidity, and not everyone will have access to curative therapies. And therapies to reduce progression of NAFLD upstream as well as downstream will require societal changes as well as development of therapies we can use in clinic. The recent increase in donors is largely due to the tragic opioid epidemic. Donors with Hep C who want to donate can be considered for Hep C positive recipients and potentially as for Hep C negative recipients as well. And I will end here and take any questions. Thank you for your attention.
Thank you very much. Then I'll ask you to call on the audience, and I will just mention we're going to cut about 2 or 3 minutes before the hour for a brief announcement. Please go ahead and call on the audience and repeat the questions.
Dr. Mackey? So Dr. Mackey is asking about patient selection. Are we benefiting some patients by doing liver transplant? And the answer is it takes a lot of effort, it takes a lot of selection, it takes a large team of transplant surgeons, transplant hepatologists, social workers, infectious disease, and critical care, and the like, to select a patient, make sure that you select the correct patient who will benefit from a transplant. You're talking about survival benefit, so that your survival as a group is much better and quality of life after transplant than before transplant. And as a group, we do very well. So if you, to all the house staff and the critical care physicians, you will see the patients that need you the most. These are the patients that are in the hospital. They account for 10% of all transplant recipients. The other 90%, the easy ones, are all in my clinic. They're doing well. So that selection is happening, but I appreciate that question. Yes, go ahead, Julie. Yes. So the question is on bariatric surgery and liver and NAFLD, and possibly liver transplant. There are no randomized controlled trials that I'm aware of, but a lot of observational studies and open label studies as well, showing that NAFLD can improve with bariatric surgery. When you do it, it's tricky when you have progression. In the setting of cirrhosis, it can exacerbate. So if you lose weight too rapidly, you can exacerbate decompensation. So the timing is important. Decompensated cirrhosis, I wouldn't recommend it. There's an interesting trial from Mayo where in 7 patients, I believe they did it at the time of transplant. They just did a restrictive procedure, cutting out part of the stomach, sleeve gastrectomy, and it worked well. The patient's BMI stayed under 30 post-transplant. There was one complication of a leak at the staple site, but it's only 7 patients, so we don't know if we can apply it broadly. Post-transplant, our group has published, Dr. Fernandez published, showing good results. But again, it's a tricky operation post-transplant with all that scarring in there as well. So I think for a selected group of patients, BMI over 40 or BMI over 35 with diabetes or any other metabolic complications, who are trying to lose weight, motivated, and don't have advanced cirrhosis, it is definitely a good therapy. Oh, okay. It's $1 million question. Screening for fatty liver disease in obese patients. I wish we could. If you look at the guidelines, these were published a few years ago from ASLD, they say that currently there is no evidence to support the benefit from screening, because at this time we don't know what therapies we can give that will reverse it. And the population is simply too high. I will direct you to a review that came from Dr. Anna Locke and Tapper from Michigan about non-invasive fibrosis detection in the New England Journal in the last month that talks about this. So what's a good screening test in somebody who has obesity? There are some biochemical markers you can look at that are simple. A platelet count that is lower than 150,000 should set off some alarms and bells. Liver enzymes may not go up in NAFLD, at least a third of the time. But when they do, an AST-ALT ratio of greater than 0.8 should set off alarm bells that there is fibrosis. And there are some other things you can look at. There's a NAFLD fibrosis score. It's a calculator. It's freely available online. It includes age, these AST-ALT platelet ratios. You can put them in and see if your patient is at risk of fibrosis. The patients at highest risk are patients older than 50, long-standing diabetes, obesity, metabolic syndrome for many years, who have not been successfully able to control those conditions. Good question. It's an unsolved problem just because of the sheer magnitude so far. Yes, Ben?
Thank you, Adnan. That was wonderful. I'm taken by the
Yes, so there's great question. So Bennett is asking, given the higher prevalence of liver cancer in males versus females in a long-term study, is androgen deprivation being looked at? It has not been looked at, as far as I'm aware, in any study to show that it benefits. Is it harmful? We don't know. I know a long time ago, one of my partners did not want to give a patient testosterone replacement therapy because of this risk. So we are clearly aware of this, but it is theoretical. And at this time, there is no evidence to support androgen deprivation therapy to reduce liver cancer risk. But good question. Yes, go ahead, Sam.
In transplant selection committee meetings for alcoholic liver disease, we talk about folks who are still drinking and prioritize them on the list. Will we be thinking about pizza and whole foods with a similar way?
We don't have a pizza counselor yet, but but you're absolutely right. So Sam is asking, we spend a lot of time talking about alcohol abuse and its impact on transplant and selection. What about poor nutrition? So as part of the selection, they all meet a nutritionist, both at the VA and at the university hospital. They do get counseling, and but it is not part of the transplant process to exclude patients for poor diet. You can have patients with a BMI of 22 who have worse diet than patients with a BMI of over 40. Now, patients whose BMI, it's a poor marker, is high, over 40, they are encouraged to lose weight. They are patients with a high BMI that we will not consider if they have a lot of comorbidities, metabolic syndrome. But it's a complicated discussion that includes a lot of things: nutrition, motivation, age, as well as markers of frailty, rehabilitation, and the like. But you're right, it's an unanswered problem right now, how to assess and select for that. Thank you. Yes, go ahead.
Are you seeing a lot of recurrence with the NASH patients that we're transplanting if they're not keeping their BMI?
Yeah, it's a good question. So the question was, are we seeing a lot of NAFL recurrence or NASH recurrence after transplant? And we actually looked at this and published this a few years ago, 6-7 years ago. And NASH does recur. As far as just benign steatosis after transplant, it recurs in maybe about close to 50% in that population. The progressive form, these patients had biopsies. NASH occurred in a minority, less than 20%, and only 3% had cirrhosis over 5 years long follow-up. So we are doing well in reducing progressive liver disease, but it can recur. NASH recurs, alcoholism recurs, autoimmune recurs. So it takes a lot of effort on part of the transplant team, managing their weight, managing their diabetes, statins. It's a multidisciplinary effort with endocrinologists, cardiologists, primary care to do all this. And I think it makes an impact, and that's why the results are good. Yes, go ahead. Oh, yeah. So far, there is no recommendation for screening for ACC if you don't have cirrhosis. If you have cirrhosis, they should get screening every 6 months, whether you do it with ultrasound, cheap, readily available, MRIs or CTs is up to you. Ultrasound's easier to do, but it has some limitations. As far as who to refer to a NAFL clinic, most of the patients that will come to your attention will be the ones that have elevated liver enzymes, and then they need further investigation, or there is incidental finding of a bright echogenic liver on ultrasound done for some other reason, or on the bottom of a CT scan, and then it leads to, is that fat in the liver? If you have a patient with rheumatoid arthritis, with obesity, should you be doing screening, looking at their liver, every 5 years with an ultrasound or a fibroscan? I think we should study that. Yes, Dr. Mackey.
Does the improved or the relatively low risk of recurrent NASH if you transplant might that suggest that the immune suppressive therapy, the anti-inflammatory therapy is why you're seeing that? And if so, might anti-inflammatory therapy beyond cholesterol drugs be beneficial in ameliorating progression to cirrhosis in patients with NASH?
It's a good question. So post-transplant, immune suppression definitely impacts recurrence of NAFLD. Prednisone, in many studies, including ours, the dose was correlated with NAFLD recurrence, but even tacrolimus, which has been shown to be great for transplant recipients, improve survivals, is diabetogenic. So it does increase that risk, but you can't get away from using the immune suppression. All these patients gain weight. Post-transplant, appetite comes back. They do develop hypertension from the immune suppressive agent as well, and hyperlipidemia. So managing all of these is important, as you mentioned. And in addition, the use of anti-inflammatory agents is in research trials in non-transplant populations. If it works out and approved, I think we will see that in the post-transplant population as well. Yes.
No, I'm sorry. We're going to have to close. If perhaps people can come up the front at the end if they have any further questions. Please don't leave, but I do want to express my appreciation to Dr. Said for just an outstanding grand rounds. Before you leave, could I have our 4 chief residents stand up, please? And as you all know, we have an amazing house staff program, and among our brightest and our best, go ahead and turn toward the audience. They can see you there. So among the brightest and the best become chief residents. And a few years back, a number of us decided to provide endowments for the chief residents. I just want to acknowledge them so they can put this on their CVs and spend a little bit of money that it comes with this endowment. Specifically, Amber Hertz-Tang is now the Bridges Endowed Chief Resident. Scott Saunders is now the Page Endowed Chief Resident. Kevin Wensky is now the Vogelman and Carnes Family Chief Resident, and Peter Kleinschmidt is now the Trowbridge Chief Resident. So I want to, first of all, acknowledge the donors. I want to remind everybody here what a great opportunity it is to give to your Department of Medicine, whether it's a small or a larger donation, and to find your area of passion, perhaps even to make an enduring endowment such as this. I promise you it's not as much as it sounds. And finally, I do want to acknowledge these 4 chief residents for their outstanding leadership so far, and we look forward to a great year throughout this academic year. So congratulations to them. Thank you very much.